Bismillahirrahmanirrahim, Mr. President, my worthy teachers and dear colleagues, Assalamu alaikum. Phaco emulsification, the most charming procedure for an ophthalmologist, but this charm suddenly goes down when complications occur, even sometimes with very safe hands. But complications are not the big problem. Thing is that how you handle these complications. And this is the topic of my today's presentation, that how we handle a complication which occur during phaco emulsification. Respected colleagues, I am Dr. Irfan Qayyum, working as postgraduate training eye department in Hospital Lahore. I will present a case of 60 years old lady who received corneal burn while undergoing phaco emulsification secondary to hot phaco tape. And as a result, her corneal collagen fibers contracted and produced a highly irregular astigmatism. After 2 months, her off-scan corneal topography showed corneal burn-induced astigmatism of 5 diopters. Her visual acuity was counting figures, and as you all know that we cannot correct irregular astigmatism with glasses, so her maximum improvement with glasses was 6.24. As you can see that excellent phaco was done. If you can see the margins of the CCC, IOL was right in the back, and there was a good frontal glow. But problem was lying over here. After 3 months, her corneal topography showed astigmatism of 5 diopter. This was the anterior corneal surface, and this was the posterior corneal surface. And if we enlarge the central portion, then we can see that there was a 5 diopter astigmatism. This was the site of incision from where the phaco was done. Now we discussed this case with many consultants. Some said that simple spectacles should be advised, but using 5 diopter cylinder is not well tolerated. Some said PRK, LASIK, toric IOL, and arcuate astigmatism, astigmatic keratotomy, and then the full thickness limbal relaxing incision. We decided to go for the cheapest one, that was the full thickness limbal relaxing incision. Actually, cost was not the main issue. Main thing was that we planned to remove the contracture which was produced due to the corneal burn. More of it is simpler, less expensive procedure than other refractive procedures. And incision can easily be extended later if original procedure did not correct all of the astigmatism. This was a surgical video. Incision was made with 11 number blade. Initially it was partial thickness, then the full thickness, almost 5.5 to 6 millimeter, the same which was shown on corneal topography. Now the viscous elastic was injected to maintain the interior chamber. Then 2 loose stitches were applied just to close the lips of the wound, so that if there is any overcorrection, they can be removed later on. On her first post-op scan, there was a mild reduction in her astigmatism. Initially it was 5 diopters, now it was reduced to 4.3 diopters. But there was a dramatic change in her astigmatism on her second post-op. Now astigmatism was reduced to just 0.5 diopters, which was initially 5 diopters. And you can see the shape of the cornea, now it's totally regular, and there is no astigmatism shown on corneal topography. On her third post-op scan, it was reduced to just 0.4 diopter, and on her fourth post-op scan, it was reduced to just 0.3 diopters. And her vision, which was counting figure initially, was improved to 6.6 partial without classic. And now if we compare pre-operative and post-operative, then we can see that when corneal topography was this, her astigmatism was 5 diopters, and when corneal topography was this, astigmatism was just 0.3 diopters, and her visual acuity, which was counting figures initially, was improved to 6.6 partial now. And now we are happy because our patient is very happy with our management. If we conclude all this discussion, then we can say that corneal burn is relatively a common complication of phaco emulsification. Full thickness limbal relaxing incision may be useful to reduce astigmatism in some selected cases. Special thanks to Professor Sayyid Ali Haidar, Professor Mumtaz Hussain, and Dr. Qasim Latif.